Hey there, pharmacology friends. Let's just go through some atypical antipsychotics. Remember that this class of medications is designed to offset, hopefully, the extrapyramidal side effects that we see generally with typical antipsychotics, which were designed to target the dopaminergic receptors in the brain to reduce positive symptoms of schizophrenia. The atypicals not only are going to alter dopamine by doing that activity, blocking postsynaptic dopaminergic receptors, they are also going to block serotonergic receptors, specifically the serotonin 5-HT, 5-hydroxytryptophan, 2 family receptors, which include the 2A and 2C type receptor. The type A receptor, when you stimulate it, seems to be the one associated with the decrease in extrapyramidal side effects, and the 2AC, or 2C, that one is associated, unfortunately, with an increase in metabolic changes. So that causes changes to satiety. So even though atypical antipsychotics have decreased chances of causing extrapyramidal symptoms, they have increased chances of causing metabolic issues. And that's what we have down here. So they block dopamine and serotonin. Some atypical agents are listed here. Right now it is 2023, and what month is it? Almost spooky month, it's September. So things that are on the market in the United States currently are listed here, and you might see some names that you recognize like aripiprazole, olanzapine, quetiapine. These medications are used for schizophrenia. They can be used for psychosis. They are used in bipolar, especially bipolar type 1 with mania, which can progress into psychosis in some cases. There's also things like Abilify, which are also being used now as adjuncts in depression. So let's just go through a couple of FAQs about each med. Okay, so let's start with aripiprazole, and not only because it's first alphabetically, but also because it's a little bit different than the other atypical antipsychotics. So it is the only one that really isn't going to be acting mainly as an antagonist. Instead, it is specific for the presynaptic D2 receptor. So let me draw that. That was fast. All right, so we've got our D2 and D1 receptors, D1 being primarily postsynaptic excitatory receptors, so that when dopamine would bind, we would excite this neuron, whereas D2 receptors, if dopamine bound to them, they would signal a decrease of dopamine production and release. So aripiprazole, sold as Abilify, is specific for this D2 receptor. So it is decreasing dopaminergic transmission, especially in the mesolimbic system, by natural D2 inhibitory mechanisms. It does have the stereotypical 5-HT2A antagonism. So it antagonizes that receptor, agonizes the D2 receptor, and then finally, it is also a partial agonist at a 5-HT, so a serotonin type 1 receptor, which is postsynaptic. So it decreases receptor activity associated with extrapyramidal symptoms, but it also alters some activity in the regular serotonergic mood pathways, which might help with sleep and mood disturbances. That's also why you see this medication used in depression. This med can be taken orally as a tablet, also as a solution that can be drunk or swallowed. There's an oral disintegrating tablet then that would be used to either go the buccal or sublingual route so that you can bypass swallowing it. And there's also IM depot injections. Remember, depot means that it's in an oily medium and it can last for a long time. Some of these formularies can last weeks and others months, and that really helps with maintaining level of a drug and helping with therapeutics. That being said, this medication also has a high therapeutic window or a wide one, meaning that the dose you need for it to work is really far away from the dose you need for toxic side effects to occur. It also has relatively low risk of metabolic effects. It is going to alter serum prolactin, in this case lowering it, so not increasing it like some other medications. And when there's abnormalities with motor movement, we can see that we can mitigate them in the simplest way by giving a lower dose and also giving it at bedtime when patients are less likely to notice motor disturbances. So that's our first med. Moving on. We have asenapine sold as Safras, and this has a typical atypical mechanism of action in that it is designed to antagonize D2 and 5-HT2A receptors, so dopamine and serotonin. One thing that's special about this medication is that if you swallow it, it isn't going to get to the system. 98% of it is removed by the liver in the first pass effect if swallowed. That means it's mainly going to be available in other routes. There's an oral disintegrating tablet that has to be absorbed under the tongue or by the buccal inside of the cheek route, because if you swallow it, you're going to get it sucked up by the liver. So there's also a transdermal preparation to avoid the mouth altogether. There is a low risk of metabolic effects with this medication, and there's also limited other drug interaction. So you can take it with a variety of other things. Next up, we have iloperidone, sold as Fanapt. This medication gets a little messy. It antagonizes the receptors we would expect, the 5-HT2A and the D2, but it also antagonizes another postsynaptic dopaminergic receptor, the D3, and to make it problematic, an alpha-1, which is what norepinephrine would typically bind to. So if we think about alpha-1 agonists, for example, those would be things like a decongestant that would hit that receptor and increase blood pressure in that area to relieve congestion. If we're blocking alpha-1, that's going to do the opposite. That's going to make vessels big and dilated. So when you take a dose of this medication, that means it's going to alter some sort of blood pressure regulation. So it is recommended that you titrate the dose to help minimize changes in pressure with regards to how you're sitting or standing, and you don't get dizzy when you stand up. There's a daily protocol that you can check out by clicking right here, so that you very slowly go up in dose. So we try to do that around bedtime so that if there's a big change in blood pressure, at least the patient is sleeping and is not in a ton of danger of falling. And there's also lower chances of metabolic effects with iloperidone than some other atypical and then definitely typical antipsychotics. All right, now we have a really new med. The FDA approved it in 2021. Lumateperone, or Caplyta, is a medication that blocks the serotonin 2A and then also a whole array of dopaminergic receptors, so D2, 3, and 4. There's also some GABA effects which help with decreasing neuronal excitation, but that also can be a little sedating. But don't forget that GABA increase is what is necessary to relieve anxiety. So it can be helpful for those with paranoia, and those types of persecutory delusions. Very low risk of anticholinergic side effects, sedation, weight gain, low blood pressure. So that's good. And also very low risk of extrapyramidal side effects, metabolic and endocrine adverse effects. And that's because it is super specific. It is hitting all of the right places. That also means it's going to be very expensive. The more specific and new a drug is, the more it tends to cost. So it's going to be on patent for a while. The cost won't come down for about a decade, but you can check out this new medication, and there's very good profiles associated with its use. Okay, next up, lurasidone or Latuda. That's another popular medication. It is pretty stereotypic in its mechanism of action. It is a full antagonist, meaning it fits super well to the receptor and has a full expression of activity at the dopamine type 2 and the serotonin 2A receptors. It is only available oral, and with schizophrenia, there's only one dose that's approved by the FDA for use. So if you're treating bipolar or depression, you'll have a greater range of doses, but schizophrenia, just one dose, and it's only oral tablets. There's a relatively low risk for anticholinergic side effects with Latuda, and sedation, weight gain, low blood pressure. It has a lower end risk of metabolic adverse effects. One thing that is special about it, aside from it being a full antagonist, one dose, is that it is necessary for you to eat for it to be absorbed. At least 350 calories of food should be consumed with the medication, and it's recommended that that's done before bedtime. Paliperidone or Invega is another D2 serotonin 2A antagonist. It is available in a couple of different formulations, which makes it different. So it's available in an oral tablet, an extended release oral, which is not approved in the United States for schizophrenia, but does exist and is used for other reasons. And it's also got a couple of different depot IM variations. So it is named for how often you take it. So there's Sustenna, which is a 1-month injectable version of Invega. There's Trinza, which is something people get 4 times a year. And then I just love this name, Half-Yera. Invega Half-Yera. You take it half a year at a time. So it's a twice-a-year injectable. And I mean, that's a great name. It really is. So its real benefit is its availability in these extended release versions. It, with its side effect profile, isn't perfect. It has a moderate risk of metabolic effects and pretty high rates of prolactinemia. But if we look at the rates of hospitalization, those are pretty profound. So adults receiving just the 1-month preparation, when they were inpatient because of some sort of psychiatric emergency, we see a big change with readmission when compared to people taking atypical oral antipsychotics. So within 30 days, we saw a 21% reduction in readmission. Within 60 days, 22%. 3 months later, we're still hovering around that 1/3%. So that versus the oral atypicals is very significant. And when you're thinking about things that are positive about our Invega, we have our IM preparations, nice steady levels of the drug, infrequent dosing, and really profound risk of not being readmitted. Okay, olanzapine. This is one of the older atypicals. This is sold as Zyprexa. It's a D2 5-HT2 antagonist, and it's also, you can tell that it's older because it's doing some stuff we might not want. It's also got a lot of activity at, look at all of them over here, the alpha 1, the histamine type 1 receptor, the muscarinic type 1 receptor, and the 5-HT2C. And remember, the 2C is the one that's associated with appetite. Our alpha 1 is our heart rate and blood pressure. Muscarinic type 1, that's a cholinergic receptor, so that's our anticholinergic side effects. And if we antagonize a histamine receptor like an antihistamine, we get sedation. So its effects, its mechanism of action, tell us exactly what its side effect profile is going to be. It is available as an oral med in solution, as an oral disintegrating tablet, and also with an IM depot injection. This is a medication you want to check whether or not your patients smoke, because its dose does differ with smoking, because we're hitting cholinergic receptors and nicotine hits nicotinic cholinergic receptors. The dose will be altered with smoking status. The risk for metabolic side effects is high. The anticholinergic side effects are high and get higher with dose increases, but it does seem to be helpful with positive and negative symptoms, and it is indicated for bipolar disorder with a protocol that includes fluoxetine, so an SSRI with it. Lybalvi is a new formulation. It's a combo tablet that's approved for use with schizophrenia, bipolar with mania or mixed episodes. And this pill combines olanzapine plus a medication called samidorphan. And if you see orphan in something, that means that it is opioid related. So this is an opioid that works to blunt appetite. So this could offset a little bit of the weight gain you would expect by antagonizing that serotonergic receptor. And that seems to be helpful for, again, schizophrenia and non-remittent bipolar disorder, specifically those mixed episodes which involve both symptoms of mania and depression concurrently. So that is new and that is available, and that's your olanzapine. All right, another old standard is our quetiapine, and that is sold as Seroquel. And this is a pretty popular one with regards to its mood stabilization abilities, use in schizophrenia, bipolar disorder, and also depression. D2 and 5-HT2 agonists, and we can tell this is an OG med because it's a little dirty. It's hitting some other receptors besides our ones that we're trying to hit. So it's got some alpha antagonism, histamine antagonism, and some agonism of serotonin. So this lets me know it's going to cause heart rate and blood pressure alterations. It's going to cause sedation, but it also might help with sleep and mood because we're hitting a postsynaptic serotonergic receptor and we're exciting it. So it can help with mood. It's taken orally. It does have a pretty high risk of metabolic adverse effects when it's taken at the dose indicated as therapeutic for schizophrenia. Again, its receptor activity is going to tell us our side effects. It does have lower rates of extrapyramidal side effects, difficulty with motor movements, and hyperprolactinemia than some other medications, and it is really useful in bipolar disorder. So even if it's not the best med for your patient, if they are suffering with bipolar disorder, it can be really helpful for them. So this is a broad spectrum dirty drug, but it does what it's supposed to, and some people can tolerate the side effects. All right, another old school drug. I can tell because of its activity, serotonin and D2 antagonism, but also your ones you don't want. We've got some histamine antagonism and then alpha 1 and alpha 2 antagonism. So it's blocking both types of norepinephrine stimulation that would both increase and decrease vessel tension. So just kind of know that that's going on. It is available orally in solution, oral disintegrating tablet, and also this kind of microcellular sub-Q gel preparation for a depot injection. But it is well absorbed orally, and it does have an active metabolite, which lets us know that it has a nice long length of activity. Risk of metabolic effects is moderate. Prolactinemia is pretty high, and it is also indicated for helps with tics in Tourette's syndrome or in motor tics that are prevalent in any kind of psychiatric disorder that you are treating. All right, then we've got ziprasidone, sold as Geodon. This is another, it's a dirty drug. It's hitting a lot of receptors. So our typical serotonin 2, dopamine 2, also antagonizing alpha-1, 2 different types of serotonergic receptors, the 2C and 1D, and then agonizing our postsynaptic 1A. So we can have some mood preservation with it, but perhaps some hypotension from antagonizing our alpha receptors. Lower risk of metabolic effects. This is another one of these medications that needs food. At least 500 kilocalories of food is required for absorption, and improved tolerability with food helps, especially at higher end doses. All right, finally, we have another drug that's kind of special in that it is, there's a lot of notes here for it. So it is the only drug that's effective in treating treatment-resistant schizophrenics. So that means when somebody has tried many things, maybe the better choices with lower side effects, maybe they've tried a million things, but clozapine or clozaril is really helpful for resistant patients. So schizophrenia with suicidality or polydipsia or persistent impulsive aggression, resistant mania in schizophrenia or bipolar disorder. It does hit quite a bit of different receptor types. So it's D1, D2 agonist. It's also a 5-HT2 antagonist. So it's doing all kinds of interesting things to decrease dopamine, but also hit those serotonergic receptors. It also has a high affinity for muscarinic, so that lets us know we're going to have anti-muscarinic side effects. We're also antagonizing histamine type 1, so we're going to get sedation, and then our alpha-1 antagonism will lead to lowered blood pressure and altered heart rate. So we do have some side effects along with it, but it is really helpful with our treatment-resistant patients. It is available oral in solution, oral disintegrating tablet, or IM depot injection. Huge dose range and therapeutic index. So nice wide range of doses available. However, the dose does differ between males and females and smoking status. So knowing the biologic sex of the patient and then also how much they're smoking because of the high cholinergic binding with this med is really important and does determine dose range. So do know, because it not only does it hit these other receptors, it's got a high affinity for them. So its chances of anticholinergic side effects, sedation, weight gain, low blood pressure, metabolic effects, constipation, they're high. The constipation, because it's anticholinergic, anti-rest and digest. Part of digest is moving food along and defecating on a regular schedule. So it's recommended that it's managed pretty aggressively by giving some sort of medication that causes diarrhea or a stool softener. It can also cause, if we look at rhea, like diarrhea, sialorrhea is excessive salivating or drooling. That can be managed with local medications like atropine given sublingually or different sprays. This is something that you have to sign up the patient and the provider for because it requires such frequent hematologic monitoring that it is mandatory that the patient is registered for it. So yeah, really have to keep your eye on it. But here's why we even care about a drug with so much of a negative profile. It is one of the only medications that is effective at treating the negative symptoms associated with schizophrenia. And specifically, you don't see the type of cognitive changes you see with other medications. Instead, we see that core deficit that exists in different schizotypal disorders is improved. So verbal fluency goes up, psychomotor speed, which is the rate at which you can think about things and make decisions, solve problems, learn, make memories. That's all improved, all on top of the fact that we don't see any extrapyramidal symptoms with this. So when you think of clozapine, think of a whole, symptom profile, but also think of recurrent and treatment-resistant patients. All right, so here's your summary with our antipsychotics. So if you watched my other video, or maybe you saw me in class just, an hour ago, you may have learned about the different types of antipsychotics. We had our first generation typical antipsychotics, which mainly block D1 and D2 receptors to decrease dopaminergic transmission. And if we're doing that in the limbic areas, we're decreasing positive symptoms of schizophrenia. But when we block dopamine receptors in other places, like the basal ganglia, that's how we get extrapyramidal side effects. Those medications are also hitting histamine receptors, muscarinic receptors, and some serotonergic, but also alpha receptors. So there's a lot of adverse side effects associated with them. They are effective, they are pretty cheap, and they're indicated for things like acute mania or acute psychosis and delirium, like with haloperidol, really high potency first gen agent. But because of their side effect profile, they're not first line. Our second generation are atypical. They are first line. So they are dopamine antagonists, specifically D2, most of them, but they're also going to offset that, hopefully, by antagonizing the 5-HT2 class of receptors. So an example of those is aripiprazole or Abilify. Lower chances of side effects, mainly extrapyramidal side effects, but they are higher in their ability to cause metabolic side effects. But those EPS are really what we're concerned about, which leads these to be our first line therapy. So those are your atypical antipsychotics. All right, everybody, I hope that made sense. I hope it helped, and I hope you learned something, and I hope you stay smart.